Good afternoon.
Good afternoon, Madam Chair.
Thank you. Thank you for visiting the Senate Finance Committee. Today's going to be a little different because the House is working on the budget and they're on the floor. So we're going to be bringing up representatives from the various House members. And we may have to take a pause while we wait for people, but we are going to start. So we're going to start with House Bill 992, Business Regulation, Maryland Franchise Registration Disclosure Law, and we have a representative from Delegate Mark Corman. Oh, it's our intern from last year, Connor. Yay.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the Senate Finance Committee. It is great to be back with you all today. For the record, my name is Connor Curran, and I serve as Delegate Mark Corman's legislative aide. He sends his regrets as he's not able to be here as they are working on the budget and the House of Delegates. So I'm here presenting to the Franchise Reform Act. We have worked with stakeholders to create the product in front of you today to make sure the program is truly beneficial. The bill establishes a pilot program to expedite the review of the franchise registration renewal if the franchisor provides a certain information no later than 30 days after the end of the registrant's fiscal year. The bill extends franchisee rights by allowing them to bring claims under the law within 3 years of the grant of the franchise or within 2 years of the franchise being open to the public, whichever is later. Additionally, the bill allows Maryland franchisees to join a franchise association. Finally, the bill requires the Securities Commissioner and the Attorney General's office to report the effectiveness of the pilot to this committee. The Franchise Reform Act serves as the first step in a larger goal of fully overhauling the franchise process in Maryland so that we can implement a process that rivals our neighbors in efficiency and allows more Marylanders to pursue business ownership through franchising. The legislation passed the House on a bipartisan basis, 137 to 0, had no opposition testimony. With that, I urge a favorable report. Thank you.
Thank you, Connor. Do we have any questions for Connor? And I see you only had one favorable amendment. Everybody else was favorable, so it looks good.
Yep.
Thank you for your testimony.
Thank you.
Nice to see you today. Next, we have, if we have someone here for House Bill 765, Delegate Julian Ivey. Do we have a representative? Thank you. This is hospitals, medical debt collection, sale of patient debt.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. My name is Paul Andrews, and I'm here on behalf of Delegate Julian Ivey to present House Bill 765. As amended, this legislation allows local governments and nonprofits to purchase for the purpose of forgiving medical debt. The legislation is not tied to ARPA funding and is completely enabling. Thank you all for your time today and consideration, and we're asking for a favorable report.
Question, did we put an amendment on our bill, didn't we?
This bill does not have a crossfire.
Okay, this is a little, we have some bills that weren't quite crossfile, so thank you for your testimony. Do I have any questions for House Bill 765? No questions. Thank you for your testimony.
Thank you.
Next, we have House Bill 881, Family Investment Program Child Support, a representative for Delegate Emily Shetty.
Chair Beidel, Vice Chair Hayes, and esteemed members of the Senate Finance Committee. For the record, my name is Chloe Shoemaker, and I'm here on behalf of Delegate Shetty. Thank you for the opportunity to provide testimony in support of House Bill 881. Imagine a policy that would help families access money they are entitled to, help lift families and children out of cycles of poverty, and maybe even save the state some money while doing it. That's what HB 881 seeks to do. This important piece of legislation is a step towards improving the financial stability for Maryland residents by ensuring that custodial parents receive the full benefits of child support payments to which they are entitled. Under current policies in Maryland, some of our most vulnerable families receiving assistance from the Family Investment Program often do not receive the full amount of their child support payments. Instead, this money is funneled through the state which then only passes through up to $100 for one child and $200 for 2 or more children to the family. The rest of the child support payment is kept by the state and the federal government. Here's a quick example on how this issue plays out. Let's say there's a Maryland couple that has one child. If they split up, the mom is now the primary custodial parent of the child, and the dad is ordered to pay $1,200 a month in support. If the mom's income is over $560 per month, then 100% of the money the dad pays to support the child goes right to the mom. But if the mom makes $558 per month or less, then she is eligible to enroll in TCA benefits. At this point, instead of getting $1,200 per month of child support, the mom and child would only receive $100 of that total. If the couple had 2 or more kids, then the mom gets only $200. What happens to that balance? The remaining $1,000 to $1,100 is kept by DHS, and a portion is sent back to the feds. This issue is one that is very close to Delegate Shetty's heart as someone who has lived through this, and she regrets that she's not able to deliver this testimony herself. She's very transparent that she grew up in poverty. During her childhood in North Carolina, her family received government assistance. She was raised by a single mother who worked tirelessly to support the family. Unfortunately, her dad was not in the picture and frequently chose not to pay his child support order. As a result, her mother went into deep debt to keep a roof over their heads and put food on the table. They could not afford their electric bills. Delegate Shetty remembers many nights of doing homework by candlelight. When her dad decided to update his passport, a federal law kicked in that required him to pay all the money he had owed in back child support payments. Unfortunately, however, not a single penny of this went to her mom. Years of child support payments that were owed to her mom went to the state and federal government, further deepening the debt owed and lengthening the poverty that Delegate Shetty's family went through. As passed by a bipartisan effort in the House, HB 881 addresses this issue by phasing in a requirement that all child support payments, 100% of them, are directly received by the family, regardless of whether they seek assistance with the Family Investment Program. DHS estimates that this phased approach means that the fiscal impact will not be fully realized until fiscal year 29. It is critical to provide money and services to the families that need it most and ensure that our state's most vulnerable populations have access to the assistance that they need. Ensuring that child support reaches the families it is intended for is both a moral and economic imperative. HB 881 will alleviate financial burdens to those benefiting from necessary services designed to help, not to harm them. It can and will help us reduce reliance on these programs as well, potentially saving the state money while lifting families out of poverty. Delegate Shetty would like to thank DHS, which has been working very collaboratively with herself and Senator McCray, the cross-file on this bill, to identify potential amendments that have helped significantly reduce the fiscal note. Thank you for the committee's consideration, and we respectfully request a favorable report on HB 881.
Thank you for your testimony. It's something I'd never heard before, so I really appreciate the testimony. Do I have any questions for this representative? Senator Haight?
Thank you. I know your testimony was that you guys are working on amendments. Do you think you guys will have anything to us anytime soon?
Yep, sorry about that. That might have been my human error there. They were submitted, so the amendments will now phase in this program over the course of several years. That has been submitted. It should be kind of in the record already, but the phase-in program will hit by, I believe, like fiscal year 2028 is when 100% of all child support payments should be received. And prior to that, the first year is something like 25%, 50%, 75%. So it's over the course of 4 years.
Were those amendments already adopted in the third reader
Yes.
copy? So the bill before us is as amended as you want to
Yes,
present?
yep.
Gotcha. Okay. Thank you, Madam Chair.
Thank you, Mr. Vice Chair. Important information. I don't see any other questions. Thank you very much.
Thank you.
We will tell Delegate Shetty that you did a great
Oh,
job.
thank you. Appreciate that.
House Bill 971, Anne Arundel County Crownsville Hospital Memorial Park Advisory Committee. This would be a representative for Delegate Andrew Pruski. Do I have someone here? It was not a cross-file, was it, Senator Guile? This would be your district.
Madam Chair, there was no cross-file.
Okay. I was just,
I can text message. Skipping over.
okay, that's fine. We'll move on. House Bill 1007, Disability and Life Insurance. Is someone here from Delegate Melissa Wells? Okay. Delegate Kim Taylor, 1021, Real Estate Appraisers Licensure and Certification Qualifications. We were really on a roll. House Bill 1053, Delegate Jason Buckle, Developmental Disabilities Administration, Self-Directed Services. Okay. House Bill 1066, Commission on Behavioral Health Treatment and Access Work Groups, Delegate Sheila Ruth. Anybody here for Delegate Ruth? House Bill 1091, for Delegate Stephanie Smith, Baltimore City Sheriff's Office, Collective Bargaining. Anybody here for Delegate Smith? House Bill 1251, Hospitals and Medical Professional Liability Insurers, Obstetric Services Policies, Delegate Karen Tolles. Anybody here for Delegate Tolles? I thought he was coming up. He's going back. Okay. House Bill 1051, Medical Records Notice of Destruction Method, Delegate Jesse Pippy. Well, thank you. House Bill 1510. Okay.
Madam Chair, Mr. Vice Chair, and esteemed members of the Senate Finance Committee. For the record, my name is Andrew Zirkle, and I am here on behalf of Delegate Jesse Pippy in support of House Bill 510. So hopefully I can make this quick because this is a one-word bill, and it is a technical correction to a bill that was passed by this committee last session. So House Bill, for some context, last year, Delegate Pippy sponsored House Bill 149, which made a number of revisions to statute relating to the retention and destruction of medical records and the notification thereof. We discovered that there was one minor issue that related to the notification portion of that bill. Essentially, we updated the requirements for notification such that providers would no longer be required to post a notice in a newspaper that they were destroying records, and instead they would be required to send an email notice along with a notice by first-class mail. So the key word there is "and." Providers were required to do both a letter by first-class mail and an email notice. And what we heard from some of the stakeholders that were impacted and some of our providers is that an "or" would actually work better there for a number of reasons. Firstly, we heard from the Maryland Psychiatric Association, or Society rather, and I believe they provided testimony on the Senate side as well, that there were some privacy concerns where if you required both a letter by first-class mail and an email, you might end up sending a letter regarding destruction of records to a household that may be picked up by a family member and cause some issues related to patient privacy. We also heard from some of our provider stakeholders that there were some issues related to maybe some practices that had been had patients for a very long time and were maybe smaller and weren't collecting email addresses. So requiring them to send an email to someone, a patient that they've been serving for a while, and again, maybe it's a smaller operation and they haven't collected that information, that would be something that is burdensome. And so we felt as though it would be appropriate to make this change from "and" to "or", so that way patients are still given due notice that their records are being destroyed, but we deal with that privacy concern and that issue with the overburdensome requirement. We ask that the committee give this bill a favorable report, and I'm happy to answer any questions that the committee may have.
Vice Chair Hayes?
Did you say this bill was introduced before?
So this is a technical correction to a bill that was passed last year. Last year, the delegate had House Bill 149 that, among updating these notification requirements, also required the retention of medical records to extend from 5 to 7 years. So there were a number of things that bill did related to the retention of medical records and notification of destruction. This was one of those things, and it was just an oversight. But that original bill was passed last year, and it was House Bill 149.
No, I appreciate it. The fiscal note stated that there was no previous bills submitted like this, and so having a bill number is helpful. Thank you.
Absolutely, no problem.
I don't see any other questions. Thank you for your testimony.
Thank you so much.
Apparently missed House Bill 176, Delegate Jarrett Solomon. Somebody here for Delegate Solomon? Thank you.
Good afternoon, Chair and Vice Chair and colleagues. For the record, I am Eden Fisher Durbin. I'm Chief of Staff to Delegate Jared Solomon, who is still on the House floor. It's an honor to present House Bill 176, the Davis-Martinez Public Employees Safety and Health Act. Public employees deliver critical and essential services to the residents of Maryland every single day. These Marylanders keep our communities safe, they provide for safety in our correctional facilities, they ensure our public facilities and roads are well-maintained and in good repair, deliver essential behavioral and mental health services to our neediest residents, educate our children, and so much more. The Davis-Martinez Public Safety and Health Act will deliver much-needed reform for our public employees' safety and health. The bill will establish a Public Employees Safety and Health Unit within the Maryland Occupational Safety and Health, MOSH, administration to administer and enforce our state's occupational safety and health laws in the public sector. It will hold public employers accountable by subjecting them to penalties for violations of our state's workplace safety law. And finally, require the Maryland Occupational Safety and Health Administration to establish a workplace violence prevention standard on or before October 1st, 2026. With these reforms, we as a body will commit ourselves and every public employer in the state to refocusing our efforts on providing safe and healthy workplaces for our dedicated public servants. I do want to note we have worked with the Maryland Department of Labor as well as the Maryland Association of Counties on amendments to the bill to improve aspects of the implementation. We know there are some additional items to be worked out by the committees. We appreciate the support on this important issue. No public worker should leave home ever wondering whether they'll return home safe. Let's honor the memory of Agent Martinez, who was killed in the line of duty, and ensure no one else faces the same dangers. The House of Delegates voted in favor of HB 176, 135 to 4, and I urge a favorable report on HB 176. Thank you very much.
Thank you. Nice to see you in person instead of on Zoom. We've Zoomed a few times. There are some questions about the collective bargaining portion of the body-worn cameras. Have you heard that?
Yes, that's part of the discussions that are going on.
Do you think you can get a note to us about what amendments would be acceptable, or
Yep.
or if you have staff working on those amendments, will you share those with our analyst?
Yes.
Thank you very much. Do I have any other questions for this witness? Seeing no other questions, thank you very much for your testimony.
Thank you.
I think I saw a representative for Delegate Andrew Pruski come in, House Bill 971, Anne Arundel County Crownsville Hospital. Thank you.
Good afternoon. I am clearly not Delegate Andrew Pruski because he is still on the floor. For the record, I am Jennifer Garcia, his Chief of Staff, here to present to everyone House Bill 971, Anne Arundel County Crownsville Hospital Memorial Park Advisory Committee. For the purpose of establishing the Anne Arundel County Crownsville Hospital Memorial Park Advisory Committee to provide advice on the planning of and making recommendations regarding the Anne Arundel County Crownsville Hospital Memorial Park, and generally relating to the Anne Arundel County Crownsville Memorial Park Advisory Committee. For those who do not know, the Crownsville Hospital was a state-owned psychiatric hospital located in Crownsville, Maryland, in District 33. It operated from 1911 to 2004. The overwhelming majority of the patients held at this facility were African American, and it has a troubled history, which unfortunately included the mistreatment of patients. In December of 2022, the property was turned over to Anne Arundel County. There are deed restrictions on the property that require state review and approval. Many of them relate to the historic buildings that are located on the property. Anne Arundel County has plans to improve the property, and the master plan was released in February of this year with a focus on remembrance for those who were patients at the facility, but also healing, mental health, and education. Due to the complex nature of the property and the need for both local, state, regional partners, we are requesting that this advisory committee be enacted to continue the great work that is currently occurring and to provide advice on the project. Folks who are included on this advisory committee our representative from the Governor's Office, the Executive Director of the Governor's Office of Community Initiatives, the Maryland Commission on African American History and Culture, a member of the Senate that represents the district. Thank you, Senator Guile, for your service. 2 members of the House of Delegates that represent the area, a member of the Anne Arundel County Council who represents the area, a representative from Bowie State University, the Anne Arundel County Budget Officer, the Director of the Anne Arundel County Office of Equity and Human Rights, and 7 members that are appointed, additional members that are appointed by the Anne Arundel County Executive with expertise in cultural history, recreation and parks, infrastructure, health and wellness, and communities that are adjacent to the Crownsville Hospital Memorial Park, as well as civil rights. I thank you for the opportunity to present and ask for a favorable report on House Bill 971.
Senator Ellis?
Listen, this was a great bill. I'm trying to keep up with the members. Do you have like the NAACP in that list?
They are not on the list.
Okay. Would you object if we put them on?
No.
That's a big.
Would not object.
Or you would, okay, great, thanks.
Thank you.
Madam Chair.
Good catch. Thank you very much. Any other questions for Jen? No? Thank you very much for your testimony.
Thank you.
I'm going to just recheck these. House Bill 1007, Delegate Melissa Wells. Is anybody here for Delegate Wells? Okay.
Hello. Chair Beidel, Vice Chair Hayes, members of the Senate Finance Committee. For the record, I'm Matt Kramer. I'm Delegate Wells' Chief of Staff, and I'm here to testify on House Bill 1007, which you heard the cross file of, which was Senate Bill 757. House Bill 1007, as amended, safeguards individuals applying for life, long-term care, and disability insurance by setting clear and enforceable limits on how genetic information can be used by insurers. As genetic testing becomes more common, so do concerns about how the results might be misused. Many patients hesitate to pursue these tests, even when they could be life-saving, because they fear the information could be used to deny them coverage or increase their premiums. More Marylanders are turning to genetic testing to better understand their risk for cancer, neurological conditions, and inherited diseases. They deserve to do so without fear of being penalized by insurers. HB 1007 has been amended and was developed with input from both patient advocacy groups and insurance industry stakeholders. It brings Maryland in line with a growing number of states that recognize the need for modern, balanced protections in this rapidly evolving area of medicine. What HB 1007 amendments do is it requires consent. Insurers must obtain written permission before accessing an individual's genetic test results. There are no penalties for saying no. So patients cannot be denied coverage or charged more simply for choosing not to share their genetic information. No forced testing. Insurers are prohibited from requiring applicants to undergo genetic testing or genome sequencing, and ensures fair use of medical data. Any medical information used in underwriting must be directly related to actual risk and not unfairly discriminatory. Many of you may remember last year I testified on this bill because it is quite personal to me. My mom passed away from ALS 3 years ago, and that is a unfortunate disease that can either be genetic or environmental. And luckily, in our case, my mom was denied coverage anyway and went and got genetic testing because we knew it would not hurt anything for her, and it happened to turn out environmental. However, in other ways, if it would have been familial, me, my brothers, and my sister could be facing a very different case. And we know the cost associated with this because we had to pay it all out of pocket, and we had to take care of my mom for the time she had left after her diagnosis until she inevitably passed away in my arms. So this is a deeply personal bill to me. This was worked on very hard over the last 3 years, and I really hope we can find a favorable report here. Thank you.
Thank you for your testimony. I'm very sorry about your mom. I know
Thank you.
that's a terrible disease, but
Thank you.
thank you for making this such an important bill. Do I have any questions for this witness? Seeing no questions, thank you for your testimony.
Appreciate you, thanks.
Okay, we have House Bill 1053. I understand there's someone representing Delegate Jason Buckle, Developmental Disabilities Administration, Self-Directed Services.
Madam Chair, Mr. Vice Chair, members of the Finance Committee, for the record, my name is Tori Laird. I serve as Chief of Staff to House Minority Leader Jason Buckle, who unfortunately is still stuck on the House floor. I'm here today to present HB 1053, Developmental Disabilities Administration Self-Directed Services. This bill is a direct response to a constituent's concern, highlighting the real-world impact of our government agencies. HB 1053 clarifies that parents of recipients of self-directed services must have the option to provide specified services for their children. Additionally, it revises the conditions under which a family member or legal guardian may serve as the provider. This is a straightforward yet meaningful measure to ensure greater flexibility and support for families navigating self-directed services. On behalf of Delegate Buckle, I respectfully urge the committee's consideration and a favorable report on this bill.
I didn't get that. Could you try again?
Sorry, my watch went off.
I have that problem all the time. Do I have any questions for this witness? I see no questions. Thank you for presenting.
Thank you.
I hope they let your delegate off the floor soon.
Me too.
House Bill 1021, did somebody come in for Delegate Kim Taylor by chance? Okay. And has someone come in for Delegate Sheila Ruth yet? Come on up. This is House Bill 1066, Commission on Behavioral Health Care Treatment and Access.
Hello. Thank you, Madam Chair, Mr. Vice Chair, members of the Finance Committee. For the record, my name is Caitlin Scanlon. I'm Legislative Director for Delegate Sheila Ruth, and I'm here to present House Bill 1066, Commission on Behavioral Health Care Treatment and Access, Membership and Work Groups. By now, it is impossible to deny that substance use is a public health crisis. One does not need to wait long to see another heartbreaking story in the news of just how badly it has affected our state. It's difficult to find anyone who has not been touched by this epidemic, whether they've experienced it firsthand or have loved ones who are suffering. People with substance use disorders, or SUDs, need treatment that not only works in helping them overcome addiction, but holistically helps them thrive in our society once again. We can all agree that our goal is to reduce substance use and the harms associated with it and improve public health and safety. To do that, we must first truly understand the best ways to treat and then support those with SUDs, rather than simply treating them as criminals. HB 1066 aims to do so by creating a new work group in Maryland's Commission on Behavioral Health Care Treatment and Access that would study the ever-pressing issue of substance use in our state and recommend the best ways to address them. The Commission on Behavioral Health Care Treatment and Access currently has 4 existing work groups, one regarding geriatric behavioral health, one regarding youth behavioral health, and those with developmental disabilities, and/or complex behavioral health needs, one regarding criminal justice-involved behavioral health, and one regarding behavioral health workforce development, infrastructure, coordination, and financing. These are all important groups and provide us with crucial information we need to help our fellow Marylanders. However, substance use is a complex issue that cannot fit neatly into one of these existing work groups. Although substance use is generally covered under the behavioral health umbrella, its needs vary enough from other behavioral health aspects that I believe, and Delegate Ruth believes, it requires specific focus to ensure that we're achieving the best outcomes, particularly given the massive crisis we are facing now. Further, it's our understanding that the Commission has not been able to give much attention specifically to substance use. As such, this bill would add a fifth work group regarding the improvement of health, social, and economic outcomes related to substance use. This work group would evaluate the availability, affordability, and accessibility of treatments and recovery support services, including housing and employment support, for those with substance use disorders in the state of Maryland. And the various effects the intervention of the criminal justice system has on these services and those who utilize them, such as how many individuals are directed to the above services by the criminal justice system, the health outcomes of individuals who have received the said services after being mandated by the criminal justice system versus those who sought them voluntarily, including a review by the criminal justice system, including a review of current research of the efficacy of voluntary versus criminal justice system mandated treatment. The impact of criminal justice involvement related to substance use on the health and well-being of individuals, their families, and their communities. The fiscal impact to the state and to local governments resulting from current criminal justice involvement related to substance use. The equitability of how current criminal justice involvement related to substance use is applied, as well as the availability and accessibility of data on the aforementioned issues. Ultimately, the work group would be charged with making any recommendations it deems necessary regarding potential alterations to state laws, policies, and practices in order to mitigate the harms related to the criminalization of substance use, with the end goal being improving the public health, safety, and well-being of the people of Maryland. The bill, as originally introduced, would have added additional members to the Commission on Behavioral Healthcare Treatment and Access to represent organizations with expertise in substance use and individuals with lived experience. The House Health and Government Operations Committee amended out that section so as not to burden an already large commission with additional members. Finally, we need to recognize that those requiring help with substance use related issues need real support and deserve to be treated with dignity and respect as the fellow members of our community that they are. That recognition requires an understanding of their needs, of what really works and what really does not, and a work group studying just that is the first step that we need to take. I ask for a favorable report on House Bill 1066.
Thank you for your testimony. Do I have any questions for this witness? Thank you for this good bill. Thank you.
Thank you very much.
I saw Delegate Banderi come in. I think you kind of snuck off the floor to be here for us. So I'm going to take you out of order so you can get back to work.
Yeah. Thank you,
House Bill 1310.
Madam Chair, Vital Vice Chair, Hayes, and committee member. I'm proud to present House Bill 1310, which expands Maryland's prescription drug repository program by including out-of-state pharmacies boosting access to affordable donated medication. A 2022 survey showed 55% of Marylanders face healthcare cost struggle, with 23% rationing mates. Nationally, $11 billion in unexpired drug, including $5 billion from hospital and care facilities, are wasted yearly. This bill redirects those drugs to patients, cutting waste and costs. Since 2006, our program has been limited to 2 pharmacies only. SB 1310 enables multi-state partnership with drug donation leaders. I have amendments as well. They address technical updates recommended by regulating agency, clarifying the framework and rules for out-of-state repository. And I urge your favorable report, and I have Andrew York, Maryland Prescription Drug Affordability Board, and George Wong from Serum to testify on this bill.
Delegate, have you already put the amendments on the House bill? Okay.
Yes.
I just want to make sure we have them. Do we, you want to just see if we have any questions for Dr. York? He's here for information, right?
Yes.
Okay, do I have any questions for the delegate, for Dr. York? Senator Ellis.
Thank you, Madam Chair. And I should maybe thank you for this bill, Delegate, because I don't understand it. I don't understand what a repository is. No, I'm serious. I mean, I'm trying to keep up with all the bills going through here, and I'm trying to listen. So what's a repository, prescription drug repository program?
So
What's
the
that term?
Maryland, I can answer it. Andrew
Sure,
York,
yeah.
Executive Director of the Maryland Prescription
Can
Drug
you
Affordability
get the
Board.
mic?
Oh, excuse me, thank you. Andrew York from the Maryland Prescription Drug Affordability Board. Maryland has a repository program that allows Maryland pharmacies to accept donated drugs and then redispensing them to high-need patients. Normally, these drugs will be just thrown away, so instead they're repurposed and provided to patients. This program expands it to out-of-state entities. There's some very successful and capable out-of-state pharmacies that want to do work in Maryland and serve Maryland patients.
Okay, so repository is another word for like a warehouse where these
Yes,
are
a entity that
stored?
can receive donations and then
Receive donations.
redistribute them.
So who does the donations come from?
They can come from often nursing homes, hospitals, folks that deal with a high volume of medications that they often have to throw away. So usually in industry, larger entities that have high volumes of medications.
Yeah, okay. And so who would benefit from this?
Maryland patients, you can go to a website and go to the pharmacy that partners with the repositories, and then you can get donated prescription drugs at a nominal cost, basically delivery fees.
Okay, so this program exists now, but you said only 3 pharmacies in Maryland?
Yes, in Maryland, if it's just in-state pharmacies, it's just a very small program. When you expand it to out-of-state, it turns it into a much larger program. And with these repositories, it's very important to match the donated drugs to patients. So the more donated drugs you have coming in, and the more patients you come in, the more you can match. Yep.
Yeah, so how many Marylanders you think participate in this right now? I know it's limited, but.
So it's very small for in-state only. I don't have numbers, but there's 2, I would say, independent pharmacies that probably have very low volume. The goal of this bill is to expand the volume to hopefully hundreds, if not thousands of Marylanders.
And is there a plan to notify Marylanders of this availability?
Yes, I think that's part of the reason why we are supporting this is we're providing technical support and helping with rollout to notify patients about this. So often patients come to the Prescription Drug Affordability Board. We're hoping to be able to refer them to these repositories as a source for affordable prescription drugs.
So when I have constituents asking me about, just send them to your board.
Yes, and we'll also send out notifications so they can go directly to the website. This one, the partner pharmacy is called Good Pill. They're already licensed in the state, so folks can start using this service today.
Okay, very useful. Thank you for educating me.
Thank you.
Appreciate it. Thank you. Thank you, Madam Chair.
Vice Chair Hayes?
Can you speak to the opposition from the Board of Pharmacy?
So they submitted a letter of support with amendments, and there should be an amendment before the committee today. It's a series of technical changes based on the recommended from the regulating agencies. And the amendment from the recommended amendment from the Board of Pharmacy should be included in that amendment.
Got it.
Yeah,
Got
so
it.
that the issue brought up in that letter should be addressed in the amendments before you.
Got it. Thanks.
Great.
Dr. York, are the medications checked for contamination or expiration?
Yes, that's one of the main purposes of these repositories is to guarantee the safety and efficacy of these drugs. So they often have to be donated in their original packaging. So then it's verified that they haven't been, it's called, there's a technical term for it, misbranded or adulterated. That's what I was looking for. But yeah, they do a safety check and a quality check before it's redistributed.
I happen to remember the old Tylenol scandal, and I just want to make sure that, we're sending out good drugs.
Yes, that's right.
Thank you. Any other questions? Thank you very much. Now you can go back to the floor.
Thank you, Madam Chair.
We have a favorable with amendment, George Wang. Is George here? Oh, he's virtual. I'm sorry. Hi.
Yeah, great. Thank you, Madam Chair, members of the committee. I'll be pretty quick here. I'm one of the co-founders of Serum. We're a nonprofit founded about 14 years ago, and we help operate drug repository programs in 11 states and are the national leader in the space. with the largest redistribution network of surplus medicine in the country. To date, we've helped get about 2.5 million prescriptions worth nearly $300 million to patients in need. And we've seen these programs in other states greatly benefit from allowing out-of-state entities to participate in their programs. One example of this is in the state of Georgia. In Georgia, we helped launch Good Pill Pharmacy in 2017 as a part of their repository program. Good Pill Pharmacy is now licensed as an out-of-state participant in Illinois' repository program. Dr. York mentioned also in Maryland recently. Good Pill partners with free clinics all over these states to help patients get access to medicine that they need to stay healthy. And Good Pill is poised to participate even further now with these amendments in Maryland's program, with the proposed amendments that were mentioned. So we support, obviously, this bill, HB 1310, with amendments, and ask that you do the same. We believe that allowing these out-of-state entities to participate, Maryland can become a national leader in drug repositories, benefiting low-income Marylanders who struggle to afford their medications, and preventing the environmental impact of pharmaceutical waste. Thanks for the opportunity to submit this testimony.
Thank you very much for your testimony and for your work. It's very interesting. I haven't heard it before, so thank you very much. Do I have any questions for Mr. George Wang? Seeing no questions, we now have Deborah Bricado, unfavorable, virtually.
Good afternoon, Senators. Deborah Bricado with Maryland Right to Life. And on behalf of our Board of Directors and followers across the state, we oppose House Bill 1310 without an amendment to exclude its use for abortion purposes. Maryland Right to Life always opposes the promotion and funding of abortion, including the expansion of accessibility to the dangerous and deadly abortion drugs. This bill extends the prescription drug repository program to pharmacies outside of Maryland. The state of Maryland already spends over $33 million for abortion, including the use of taxpayer-funded Medicaid to cover the cost of abortion drugs. Governor Wes Moore and the Board of Public Works spent over $1.3 million taxpayer dollars to stockpile mifepristone and misoprostol. So now this bill would have Maryland taxpayers paying for drugs going to other states. Marylanders have many other health concerns such as diabetes, wound care, heart disease, lung disease, postoperative care, etc. And the list goes on that should be addressed, but the state of Maryland prioritizes abortion. Abortion is not health care and is never medically necessary. Abortion enables the exploitation of women and girls by sexual abusers and sex traffickers to continue their crimes and victimization. This increased accessibility to abortion drugs means that abusers and sex traffickers will also have increased access. Marylanders do not want to participate in the abuse and coerced abortion of women and girls. Please keep the dangerous abortion pills out of this program. We ask for an amendment to exclude abortion purposes from this bill. Without an amendment, we do urge an unfavorable report on House Bill 1310. Thank you.
Thank you for your testimony. Do I have any questions for this witness? I see no questions. Thank you very much. And that ends the hearing on this bill. And we are going to move to, I think Delegate Vogel's here. He has two sponsor only. House Bill 1131, Public Health.
Thank you, Madam Chair, Mr. Vice Chair. Happy Maryland Day to the Senate Finance Committee. Here with House Bill 799. It was actually this body that created the Maryland Innovation Initiative University Partnership Program pilot back in 2021. That program expired earlier this year, and we were in conversation with TEDCO and Frostburg State University and Bowie State University. They shared with us the incredible benefits that these programs have had for their universities and surrounding communities and the desire to continue this program. So this legislation, House Bill 799, makes the program permanent, creates a permanent extension program while making the funding discretionary for this program. It has the support of TEDCO and the universities that were already in the program, and we also amended the program to allow for new colleges and universities that meet the necessary criteria to join as well, to expand the benefits of this program across the state. I respectfully request a favorable report on House Bill 799.
Thank you. Do I have any questions for Delegate Vogel? Seeing no questions, we're going to then go to House Bill 1131.
Thank you, Madam Chair, Mr. Vice Chair. Senate Finance Committee here with House Bill 1131. Buprenorphine and the administration of buprenorphine by paramedics is considered to be a best practice when addressing the opioid overdose epidemic. The idea for this bill started with a conversation with Councilmember Conway in the city of Baltimore, who presented this as one of the many solutions that I believe they are considering in the city as well. What the process of buprenorphine, the administration of buprenorphine, is that after an individual overdoses, when the paramedics arrive, they administer naloxone, which is standard practice. Buprenorphine removes the symptoms of withdrawal for a period of about 24 hours. That is a perfect opportunity for individuals to get into more permanent medically assisted treatment. But that period is essential because, one, you're preventing future overdoses and taking away those symptoms of pain that would bring people to continue taking fentanyl or other opioids to address that pain. So this is, as I said, a best practice. You will see a letter here of support from Senator McKay and the Fire EMS Coalition expressing support. Just in terms of what the bill actually does, it uses ORF funding to provide $50,000 in grants to train paramedics across the state. And something that is really important here that we need to look at, we convened a big group of paramedics. There are counties that are already doing this. The Maryland Office of Opioid Response, among other stakeholders. And one issue that we saw that needs to be addressed is also that we need to, in administering the buprenorphine, you have 24 hours afterwards where you have to get an individual into care, right, to make this practice work. And we have a lot of work to do as a state to figure out how to create a model that works for that. So this bill also creates a work group to study this issue and figure out how we're going to come back in future years with legislation to create that hub and spoke model to get folks into treatment somewhere in the state within that 24-hour period.
Thank you. Any questions for this witness? Seeing no questions. Thank you, Delegate Vogel. Get back to work.
Thank you, Madam Chair.
We have, I think Delegate Guyton is here in person. So Delegate Guyton, if you want to come up. And you have Rachel London and Andy Culp with you, I
Yes,
think.
ma'am. Thank you.
So this
Thank
is
you,
a
Madam
full
Chair. Mr. Vice Chair, members of the Finance Committee, it's great to be before you again. Hello. For the record, Delegate Michelle Guyton, District 42B in Baltimore County, and I am here to ask for your thoughtful consideration of House Bill 1244. Now, this is in response to a lot of what we have all heard from the developmental disabilities communities, and this is certainly a bipartisan issue that I believe most people are aware of. So I won't go into a lot of the issues directly and take up your time with that, although I'm hoping that Ms. Culp and Ms. London can add more to that. This bill establishes the Maryland Developmental Disabilities Administration Waiver Advisory Council into state law. So it's important to note that we are not creating a new council here. I'm not putting forward a new work group. This is something that is already required by Medicaid regulations and has met twice, I believe, so far this year. However, the purpose of establishing this council in Maryland law is honestly to empower the state to influence the membership and the direction of the Waiver Advisory Council and to actually make sure that they address the unique concerns of Maryland's developmental disabled constituents. So we also know that potentially there may be a loss of funding and guidance from the federal government, and this action is more important than ever. So a few changes to the council that are made in this bill adds members and expands their work to improve things that they haven't necessarily been doing well over the past year, according to many of their clients. And that includes collaboration, communication, and feedback to both the General Assembly and to stakeholders, amongst a few other changes. I respectfully request a favorable report on House Bill 1244 to support the disabilities community and DDA both in their efforts to work together for improvement of the system in Maryland. Now, I think it's really important to let you know that there was a lot of thoughtful consideration and hard work over in the House side with Chair, Vice Chair, and Subcommittee Chair in HGO. We've met with constituents and with DDA and with a lot of the providers over the last year in various work groups. And so this bill wasn't put together lightly. It's probably not as much as the developmental disabilities community would like to see, but we believe that it is important, and it also comes with no fiscal note because we are actually taking over the group that's already been formed. So with all that said, thank you for your consideration.
Thank you, Delegate. Rachel London and Andy Culp would like to go next.
I'll go.
Okay.
Madam Chair, Mr. Vice Chair, for the record, I'm Rachel London, the Executive Director of the Maryland Developmental Disabilities Council. I'm also here as Chair of the DD Coalition. You have our written testimony, and we are here in full support. I want to start by thanking Delegate Guyton. I'm also a member of the Waiver Advisory Committee, and so I want to highlight two critical parts of the Advisory Council and this legislation. First, the Advisory Council, when all the seats are filled, has a majority of people with developmental disabilities or people with lived experience. We strongly support this. In fact, my council, created by federal and state law, thanks to this committee, also has a majority of people with developmental disabilities. This bill, as it passed the House, strikes the right balance of members and keeps the membership aligned with the principle of nothing about us without us. We strongly support this balance and this alignment. Second, I want to stress that the purpose of the Advisory Council is to make recommendations about the waiver and service delivery, which happens in two models, self-directed services and the community provider model. Over 18,000 people with developmental disabilities receive services in both models, about 15,000 from providers and about 3,000 in self-directed services. Everyone works with a coordinator of community services to identify what they need and want to live and thrive in our communities. It is not just about self-directed services, as the fiscal note suggests. So the Council and the DD Coalition believes this bill, as amended by the House, strikes the right balance, and we are in strong support. Thank you.
Thank you. And finally,
Yeah, good afternoon, Chair Beidel and Vice Chair Hayes and members of this committee. My name is Andy Culp, and I'm the Executive Director of the ARC Maryland. We are one of the largest statewide advocacy organizations dedicated to the rights and quality of life of people with intellectual and developmental disabilities. We were started in the 1950s as a federated network, and so we've been around for a while and have seen a lot of things and been a part of very good changes in Maryland. Our connections and supports to families and people with IDD and representation span both models of service delivery in DDA, and we advocate for the viability of all with a lens on quality, efficiency, informed choice, modernization, and sustainability. And HB 1244 is important, as Rachel said, because it codifies and expands the duties of the existing DDA Waiver Advisory Council to provide advice and make recommendations to DDA about system design, system delivery, and quality. The waivers, additionally, it ensures the DD Waiver Advisory Council includes equal representation of people with lived experience and others, including statewide advocacy organizations like the ARC and MAX, who have supported the DDA over many years, have extensive experience with our systems of support, and advocate for individuals with IDD across Maryland. With the House technical amendments that were made that moved the ARC to the category of membership of statewide advocacy organizations, the note that's under additional comments in your fiscal note, fiscal and policy note, is no longer an issue. So that movement and that technical change makes that not an issue because the ARC Maryland is neither a licensed or a certified provider, and therefore our membership will not be cause for the removal of existing members in the Waiver Advisory Council. So I just wanted to make that clear. Thank you for hearing my testimony, and we urge a favorable report. Thank you.
Thank you. I don't see any questions from the committee. Thank you all for your testimony. We have a two favorable with amendments, Patrick Hogan and Sarah Butts.
Good afternoon. Hi, Chair Beidel, Vice Chair Hayes. Thank you for the opportunity to provide testimony today. My name is Sarah Butts, Vice President of Government Relations with Service Coordination, Inc. Service Coordination is Maryland's largest nonprofit case management organization. We employ over 1,000 team members. We serve 12,000 of the 19,000 people in Maryland currently receiving case management through DDA funding. We provide conflict-free case management to those enrolled in the DDA waiver programs and are on the waiting list, helping them navigate the eligibility and redetermination processes and connect them to vital services. We also lead a statewide community services, community of practice, coordination of community services, community of practice, comprised of a majority of CCS providers across the state. Therefore, SCI is both a CCS provider with a deep history. We've been providing these services since the 80s, and also a CCS advocacy organization. Despite our extensive involvement, we were not selected previously for a seat on the DDA Advisory Council. There's a few points that we'd like to highlight. CCS services are required for all DDA waiver participants per COMAR in Section 10948. And right now, those seats are not commensurate with the number of people served. The current reduction of CCS council seats from 2 to 1 threatens to overlook the crucial role of diverse CCS providers. These providers are nonprofit, for-profit, and local health departments, geographically located in diverse areas of the state. Just want to bring that to your attention. This change risks losing valuable insights that contribute to the effective design and delivery of Medicaid waiver programs, especially as the Department of Health seeks to control costs. We are proposing 2 amendments to ensure that SCI is guaranteed a seat on the Waiver Advisory Council and 2 seats for CCS providers are retained. This representation is vital for advising on service delivery and quality strategies. In conclusion, we urge the committee to adopt these proposed amendments to ensure that the perspectives of CCS providers are included in important discussions. Thank you for your time and consideration.
Madam Chair, I'm just here to help answer questions.
Thank you, Patrick. I was asking if these amendments were already on the House bill. Not yet?
They're not.
Before it came over? Okay. They were considered but not adopted. Okay, we'll look at them. Senator Washington?
Thank you, thank you, Madam Chair. You know, I'm hearing you loud and clear that you really just want to be on this board. Is that right?
That's right.
And what's the reason why you haven't been considered or haven't been placed on this board yet, or been placed on this board or in this conversation?
I'm unsure of the reason. I'm sure there are other providers that are interested in serving to help strengthen the Department of Health. But we do serve 50% of this population, and we want to be of service to the state and to the department.
You just want to diversify the perspective on the board.
Yes, because it's a complex system, and some of us have different expertise in different aspects of the system. And in our case, we have this expertise of CCS, and that is indeed a service that all waiver participants receive.
Got it. Thank you.
Thank you.
My vice chair has a question.
Hey, thank you. Sarah, you all submitted 3 pieces of testimony, so it became really confusing. So you all aren't included at all?
We are not included at all. There is 1 CCS seat. So there was initially 2 CCS seats on this council.
Right.
As it'll be codified, there'll be 1 seat. We do not have that seat.
Right. And so you are asking, so you do have the 1 seat that's on here?
There is a seat for a CCS provider. That's correct.
Right. And so now you need to add, you're asking to add 1 more?
We're asking to be added as an advocate organization for CCS.
Right. Gotcha. Okay. All right. Thank you. Thank you, Madam Chair.
Thank you. I don't see any other questions for this panel. Oh, I do. Senator Reedy.
So just so I understand, I see there's another group listed in the current CCS. I guess that's the CCS slot. Without getting into that particular group, not casting any aspersions one way or the other, are you guys appreciably different in how you conduct your business?
So,
and I know I'm sorry, well, you understand when I say your business.
Yes,
but
sir.
Yeah.
Yeah, so service coordination has served as a leader in this field. We actually, we chair and host a community of practice that is comprised of all the CCS providers in the state. And we already work with that group to work with the department. However, despite that role, we have not been selected as a primary provider. And we do have a unique perspective, particularly as the state is going to implement cost containment measures that will be of value to this council.
Okay, thank you.
Yes.
Thank you very much.
Okay, I see no other questions. Thank you very much for your testimony.
Thank you.
That ends the hearing on House Bill 1244. Do I have any other delegates here? Any delegates in person? Okay. We're going to go back and try to get some representatives. So House Bill 1091, Delegate Stephanie Smith. Is somebody here for Delegate Smith? Here we are. Baltimore City Sheriff's Office. Thank you.
Good afternoon, Madam Chair, Mr. Vice Chairs, and member of the committee. My name is Morgan Phillips. I am here on behalf of Delegate Stephanie Smith. I'm presenting Baltimore City Local Bill, House Bill 1091. And this bill is being introduced to fix a simple problem relating to the Baltimore City Sheriff's deputies' rights in terms of their collective bargaining. Currently, all the deputies rank of lieutenant and below, along with full-time court security officers, have a bargaining unit represented by the Fraternal Order of Police, Lodge number 22. When the initial collective bargaining legislation was passed, it was intended to allow the unit to bargain wages with the city as the county governments fund the sheriff's office all throughout the state of Maryland. So some parties originally believed that the language was unclear as to who has the right to bargain the wages. So House Bill 1091 is specifically designed to make it certain that the FOP 22 can bargain for compensation, including the wages, as part of a three-party negotiations with the sheriffs and the city of Baltimore. I do want to briefly note that the bill was amended by the House to clean up some statutory ambiguity and now makes it more clear that the FOP does have the right to bargain wages as part of the three-party negotiations, and now all three impacted parties in the interest, the sheriff's office, the city, and the FOP particularly. So the bill as it's written in its current posture is what was agreed upon by all parties. And I do want to note that the bill does have an effective date of June 1st, 2025, because the current contract does expire on June the 30th, and all parties are currently in the middle of negotiating the next contract. So should House Bill 1091 pass, it will be in effect just in time for the next agreement. And our office has been in contact with the chair of the Senate delegation, and we do expect to have the letter of support very soon. And I thank you for your time, and we'll happy to answer any questions.
I don't see any questions, but we will be watching for that letter of support.
I don't know what soon mean with this delegation these days. There was a letter from the administration. Was those amendments incorporated in the third reader copy? Yes. I see Blindy's shaking yes back there.
Yes.
Okay, thank you. Thank you, Madam Chair.
Thank you, Mr. Vice Chair. That looks like it ends the hearing on House Bill 1091. Thank you very much. Is someone here for Delegate Karen Tolles? Oh, I'm sorry, she wants to do her own bill. I'm sorry, we're going to wait for her.
I'm actually here to speak on behalf of Delegate Tolles.
She asked to go last to see if she can get here off the
Yes,
floor.
I spoke with her. I was the one that called you all to have her moved, but
So
I spoke.
do you want to testify, or are we waiting
Yes,
on
ma'am,
Delegate
if I
Tolles?
can. Yep.
Okay, you're going to testify. Okay. So we have House Bill 1251, Hospitals and Medical Professional Liability Insurers.
Chair Beidel, Vice Chair Hayes, and members of the Finance Committee. Good afternoon. I'm Leora Lala, Chief of Staff for Delegate Karen Tolles. And today, I'm offering testimony on behalf of the delegate in support of House Bill 1251, the Doula and Birth Policy Transparency Act. House Bill 1251 is a bill to create transparency in maternal health and birth policies in Maryland healthcare facilities to ensure that patients have a full understanding of the care they are receiving and the autonomy to make decisions about their own health care. This is especially important for Black women who experience some of the most stark inequities in care and outcomes in the maternal health space. Maryland has taken steps to address these inequities, including passing the Maryland Maternal Health Act of 2024, which codified essential data reporting for maternal health and patient-centered healthcare metrics. House Bill 1251 takes the next step by ensuring all patients have transparency into birth policies with the providers they choose, so they are able to safely and effectively navigate the maternal health system and advocate for the care and outcomes they want. House Bill 1251 requires healthcare facilities in Maryland that provide obstetric care to establish several patient-centered policies that lead to better communication, better care, and better outcomes. These policies include policies to ensure that patients are able to utilize doula services and do have the difficult decision of choosing whether their doula or their partner or family can be there with them during their labor and delivery. Doulas provide physical, cultural, and emotional support during pregnancy, labor, and after birth, and consistently lead to better experiences and outcomes for patients and families. This has been especially evident for women of color. Removing obstacles to these services is essential to providing equitable maternal health care. Policies that prioritize newborn bonding to the benefits of all patients and families, require informed consent for significant medical interventions, including cesarean section and medication to induce labor, which ensure patients have full understanding of what care they are receiving, any risk, and the ability to make informed decisions on their own behalf. Effective informed consent leads to better experiences, less litigation, and helps to lower the rate of unnecessary and risky interventions, and policies to ensure a clear transfer and acceptance process for patients transferring into facility care from home birth provider, which ensures that patients have a full range of maternal health options and can safely move across providers. Additionally, House Bill 1251 creates transparency in birth policies and potential care restrictions from liability insurers for healthcare facilities. Having a full understanding of all these policies allows patients to choose the practitioners and providers that work for them. Transparent information and strong communication with patients are the cornerstones of making patients feel comfortable and preserving the key role that they play in their own care. This bill is based largely on similar legislation passed in Colorado in 2021 as part of the comprehensive birth equity legislation package, and patients in Maryland deserve those same protections. It is a priority of the Maryland Women's Caucus, supported by the Legislative Black Caucus of Maryland, and supported by patients across the state. I kindly urge a favorable report of House Bill 1251, and for any questions, I would defer to Caitlin McDonough behind me.
Thank you very much.
All right.
I don't see any questions. Oh, I can't see your light. There it is. Oh,
Listen closely.
I can't read your mind.
I'm sorry.
Thank you,
You're right,
Senator.
sorry. Yeah, so thank you, Madam Chair. And so I understand the heart of this bill is to solve a problem where patient would go with their loved ones to give birth and have a doula, and hospitals, birth and facilities say, hey, no, you can choose one or the other, but both can't come in to the birthing facility. Is that correct?
Yes,
Okay, great. Thank you.
absolutely.
Thank you, Madam Chair.
All right. All right. Thank you so much.
Well done. Thank you, Senator. Do I have someone here for Delegate Terry Hill, House Bill 1478 or 1481?
Hello, good afternoon, Senators. Happy Maryland Day. Oh, yes. Is this better? Don't want to break it.
Good afternoon, Chair Bidel, Vice Chair Hayes, and members of the Finance Committee. For the record, my name is Jordan Affle, a junior at the University of Maryland and an intern for Delegate Hill this session. I'm here to present House Bill 1478, a bill that takes a step towards improving Maryland residents' access to qualified home health care providers. This bill passed the House with unanimous bipartisan support with a vote of 137-0. House Bill 1478 requires the Maryland Department of Health to report on the feasibility of creating and maintaining a public online directory of licensed home health care providers across the state. This would allow patients and families to search based on criteria such as language proficiency, experience, or certifications. For many Marylanders, especially old adults and persons with disabilities, home health care is an important part of daily life. And yet, for these individuals and their families, finding qualified providers can sometimes be difficult. In the absence of a centralized, transparent system, people may often turn to the internet or word of mouth, which are both limited. And while a Google search may seem helpful, the results that appear are usually misleading and incomplete for reasons such as the influence of online algorithms. Thus, the top providers may not satisfy a person's specific needs. This creates confusion, complicates an already difficult process, and adds stress for families already navigating challenging situations. A central directory will also help the state support home health care workforce and make response time during public health emergencies effective and timely. The report, developed with stakeholders such as the Department of Aging and residential service agencies, will assess the types of directories other states have implemented, existing Maryland systems that could be expanded upon, and what federal or state funding sources could support implementation. House Bill 1478 builds on existing work to help people find the care they need more efficiently and effectively. For these reasons, I respectfully urge a favorable report. Thank you.
Thank you for that testimony. Now, are you on the same bill or you're on the next bill?
I'm on the next one, but I'm here to answer any questions
It's
if needed.
fine. I'm just making sure I do this in the right order. So do I have any questions on House Bill 1478? I don't see any questions. Thank you very much for your testimony. And now you're going to do House Bill 1481.
Yes.
Thank you.
Hello, good afternoon, Chair Bidel, Vice Chair Hayes, and esteemed members of the Finance Committee. My name is John V. Parsai. I'm a student at Johns Hopkins and a Legislative Fellow in the Office of Delegate Terry Hill. I'm here today to present House Bill 1481, the Adapted Vehicle Access Pilot Program. The program, developed in collaboration with the Maryland Department of Disabilities, aims to provide adapted vehicles to eligible mobility-impaired adults who do not qualify for other programs offered by the Department of Disabilities. Doing so addresses a significant gap in our current support system, ensuring that more Marylanders can lead independent and fulfilling lives. This program passed the House with overwhelming bipartisan support, 137-1, and is an important step toward enhancing independence, mobility, and overall quality of life for Marylanders who require mobility aids. As a pilot program, the program will focus on individuals residing in areas with limited access to public transportation. For many, the lack of accessible transportation options can be a major barrier to employment, education, and social participation. By prioritizing these individuals, the program not only promotes equity, but also fosters greater community inclusion. The Department of Disabilities will implement and administer the program with existing budget resources, ensuring that it is managed with the expertise and care required to meet the need of eligible individuals. The program structure, which includes seeking donations and applying for federal funds, demonstrates a sustainable resource allocation and community involvement approach. Furthermore, the program's commitment to studying its impacts on recipients' independence, mobility, job opportunities, and dependency on public subsidies is commendable. This data-driven approach will provide valuable insights into the program's effectiveness and inform future decisions on extending or expanding the initiative. In conclusion, the Adapted Vehicle Access Pilot Program represents a forward-thinking and compassionate response to the needs of our community members who require mobility aids. It is a testament to our commitment to inclusivity and support for all individuals, regardless of their physical abilities. I urge you to support this legislation and help make a meaningful difference in the lives of many.
Thank you for your testimony. Do I have any questions for House Bill 1481? Seeing no questions, thank you very much.
Thank you.
Is anyone here for Delegate Heather Bagnall? Okay, I have somebody. We have two bills from Delegate Bagnall. House Bill 1046, Mechanical Repair Contracts Technical Service Bulletins. You'll do that one first, please. Thank you.
Oh, let me get my, which one do you want me to start with?
House Bill 1046.
Sure. Good afternoon, Madam Chair, Vice Chair, and members of the Senate Finance Committee. Don't let the long red hair fool you. I am not Delegate Bagnall. For the record, my name is Rory Nolan, and I'm her Chief of Staff here on her behalf today. Thank you for the opportunity to present this bill. Last year, the delegate introduced a bill in the House, House Bill 695, which would have required consumers to be notified of technical service bulletins for a motor vehicle at the point of sale. Delegate Bagnall shared with the House committee her less than unique experience of purchasing a vehicle with the technical service bulletin of a decade-long issue, which resulted in a complete engine failure requiring a new engine. As the world's unluckiest car buyer when it came to time to replace that vehicle, which still resides on her lawn, you can go over to Arnold and see it, until she can pay off the loan, she purchased a vehicle service contract to make sure that this didn't happen again on her new car. When this new used vehicle experienced a system failure, upon contacting the vehicle service contract company, she was told that the existence of a technical service bulletin disqualified her coverage because the manufacturer should have known and should have covered the repair. It was then that she learned that the largest seller of vehicle service contracts, CarShield, had to pay $10 million to settle Federal Trade Commission charges of deceptive advertising. The settlement resolved allegations that CarShield misled consumers about what its vehicle service contracts covered. Although her experience is how her office learned of these issues, they pose a significant challenge to consumers who are continually left holding the bag because the deck is stacked against them with manufacturers, dealerships, and now vehicle service contract providers all pointing fingers at each other saying, "Not my problem." But it's a big problem for consumers, costing thousands of dollars. House Bill 1046 intends to level the playing field a little bit by ensuring that if you want to do business in Maryland as a vehicle service contract provider, you cannot use the existence of a technical service bulletin to nullify a vehicle service contract. And lest you believe that this is just a Delegate Bagnall issue, my parents also experienced a similar issue with the technical service bulletin being issued for a car that they weren't aware of. It was a Hyundai whose engine blew up. And we've also had constituents who have reached out to us, one of them even on district night, approach our office and say, "Hey, can I talk to you about this really niche issue called vehicle service contracts?" So really happy to tell them we already have a bill for you. Many vehicle service contracts do actually provide coverage for technical service bulletins, but some contain language preventing service bulletins being used as the sole, some vehicle service contract providers do treat technical service bulletins as a notice of manufacturer responsibility in the same vein as a recall. This is deceptive, as a technical service bulletin is not an admittance of responsibility by a manufacturer that they have to fix an issue with the vehicle. Prohibiting this deceptive practice is just one step in protecting Maryland consumers. The bill before you, as amended in the House, has support from the Office of the Attorney General Consumer Protections Division, consumer advocacy groups, and both certified and non-certified dealers, and I therefore respectfully ask for a favorable report on this bill. Thank you.
Do you have any questions for Rory on this bill? Seeing no questions. The next bill is not sponsor only. It's House Bill 871. You're also prepared to do that one, Rory?
Yes.
Health Services Cost Review Commission, Community Benefits. It's you're also going to have Robin Elliott with you at the table, I think, in case there's questions. Thank you.
Okay, thank you. Good afternoon, Madam Chair, Vice Chair, and members of the Senate Finance Committee. For the record, once again, Rory Nolan on behalf of Delegate Bagnall. Here to present House Bill 871. You have our written testimony, so I'll summarize. Community health workers are a key part of Maryland's healthcare workforce, but their work often goes unrecognized. Delegate Bagnall and I would argue that Finance and HGO may be the only committees to understand the true essential role which community health workers play in our healthcare ecosystem, especially in our efforts to address public health disparities, because community health workers know the people and the services in their communities. They speak the language in those communities and connect their community members with services from preventative screenings and patient education to mental health and recovery services to oral health screenings. Community health workers and community-based organizations are an essential part of Maryland's public health framework. Through cultural competency and targeted community outreach, they work to facilitate access to social services and bridge the healthcare gap in underserved communities. The data is undeniable. CHWs are effective at improving health outcomes and are an integral part of our overall health system, but in many ways, they still struggle to attain financial support for their work. To provide more formal support for CHWs, HB 871 clarifies the eligibility of community-based organizations for community benefit funding and provides a memorandum of understanding framework for partnerships between hospitals and community-based organizations. There are several requirements included in the HB 871 partnership framework, including identifying accountability for patient health outcomes, developing criteria for measuring the impact of a partnership, creating responsibility for recruitment and training, and providing for insurance and other financial benefits as necessary. Nonprofit hospitals are already required to fund community benefit initiatives that address health disparities in the communities they serve. However, community-based organizations may be overlooked as potential recipients. By providing a clear framework for partnership, HB 871 encourages greater partnership between hospitals and CBOs, moving us closer to long-term support of community health workers and ensuring community benefits funding flows into the community to ensure better health outcomes in and out of the hospital. Requirements for an MOU also protect community health workers under hospital and community benefit organization partnerships by giving clear guidelines for how funding should be used to support their work and provide greater mobility for community health workers across our entire healthcare continuum. HB 871 will also provide nonprofit hospitals a clearer way to fund and support Maryland's community health worker workforce through partnerships with community-based organizations, and this bill aligns with the goal and pillars of the AHEAD model. This approach will not only benefit the community health worker workforce, but also allows hospitals to better address social determinants of health in their communities. HB 871 was amended in the House after receiving comments from advocates, community-based organizations, and the Maryland Hospital Association to give more flexibility to some provisions of these agreements. Those are shalls that have been turned to mays. And Delegate Bagnall has actually requested one more sponsor amendment, which was inadvertently omitted from the House version, which altered a shall to a may. And this amendment that is in your floor system is actually consensus between the Hospital Association and our Community Health Advocacy Coalition. HB 871 is an opportunity to help our communities and our healthcare workforce. By leveraging our community benefit dollars, we will help this very, very important workforce. And we respectfully request a favorable report on HB 871.
Thank you. Robin, do you want to testify, or are you just here for questions?
I am here just as a Me Too for several clients, the Maryland Dental Action Coalition, the Maryland Community Health System, which is a group of FQHCs, the physician assistants, the nurse midwives, movable piece, and the coordinating center. Thank you.
Thank you, Robin, for being here. Senator Ellis, you have a question?
Thank you, Chair. And thank you for Bill. What's your name, sir?
Rory Nolan.
I'm sorry, Rory?
Rory,
Rory,
yes.
Rory. I know Robin. Community health workers, we created that category of folks who use the term worker, and it turned out they're really community health volunteers. And so this bill seemed like it moves closer to make them really workers. So I getting paid. So you mentioned community benefit agreements. That's the funding for this bill to get payment to community health workers. Is that correct?
Yes. Do you want me to go into community?
Well, no, well, that's fine, that's fine. So
okay.
I was just trying to line up my question.
Sure.
So those community benefit agreements, do you know, and if you don't, maybe Robin can answer, what are the source of those funding mechanisms for those community-based agreements?
I don't have that offhand.
So community benefit agreements are, hospitals have them, and as part of their nonprofit status, they give a report every year to the Health Services Cost Review Commission, and they say how they spent those funds and invested in the community. So what Delegate Bagnall's bill is doing is allowing essentially those partnerships that they have with organizations in the communities with community health workers, allowing them to count. So when they report that to the HSCRC, it's counted as a community benefit. And so that is why community health workers are funded under these agreements through hospital resources.
Okay. Yeah, I could ask you about University of Maryland Charles Regional Medical Center, which is in La Plata, my district, but I'll let you pick any hospital to be fair to you. Do you have a number, a range of, say, one hospital, what kind of money they put into this? Okay, yeah, great, thanks. I appreciate that. Yeah. Thank you. Thank you, Madam Chair.
Thank you. Senator Reed, no question. I don't see any other questions. Thank you for your testimony. I have one unfavorable, I think. Get right back to the right bill. I have Laura Bogley unfavorable. It doesn't say virtual, though. Okay, Laura Bogley. Thank you.
Thank you.
Thank you, Madam Chair and members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life. Madam Chair, I love your jacket for Maryland Day. And if you'd allow me, I just want to also observe that today is also the International Day of the Unborn Child. And that is a day where we observe and remember the 73 million children who are killed annually across the globe through abortion violence. And in that vein, I'm here to oppose this bill that would establish a state policy and program to induce nonprofit hospitals and other medical establishments to retain and compensate abortion workers under the guise of community health. The bill would enable the multi-billion-dollar abortion industry to contravene federal Hyde Amendment restrictions on federal funding for abortion by funneling federal funds through hospital budgets and contracts. The bill also would make hospitals shoulder the cost of providing health insurance benefits to these abortion industry workers. While this is being introduced as a voluntary program, the Assembly is likely to make this a compulsory requirement for all hospitals in the future. And I want to reference the EMTALA bill that is still alive in the Senate this session. The state has already forced state taxpayers to pay nearly $15 million just last year to train a new substandard abortion workforce. This program is likely to make state taxpayer funding for abortion workers increase. Induced abortion is not health care and is never medically necessary and confers no community benefit to the people of Maryland. Hospitals in Maryland already routinely comply with the Federal Emergency Medical Treatment and Labor Act by providing emergency medical intervention for pregnant women experiencing legitimate life-threatening complications like ectopic pregnancy or miscarriage. And so for these reasons, we would urge your unfavorable report. Thank you.
Thank you for your testimony. I don't see any questions. Thank you. That ends the hearing on House Bill 871. I'm going to go back. There is one more bill that we didn't hear yet, sponsor only, for Delegate Kim Taylor, House Bill 1021. Is the representative here for Delegate Taylor? Thank you.
Good afternoon, Chair Bidel and members of the Senate Finance Committee. My name is Talise Arce-Reed, and I am the intern in the office of Delegate Kim Taylor, who represents Prince George's County's 23rd District, and I am here on her behalf to present House Bill 1021. As we are all aware, the real estate appraisal industry is an essential part of the Maryland's housing market. In 2022, the Task Force on Property Appraisal and Valuation Equity was established to address the persistent misvaluation of property owned by Black Marylanders. The task force has finished its work and has several recommendations that seek to remove unnecessary educational barriers that prevent many capable individuals from entering the appraiser industry, particularly those from underrepresented backgrounds. HB 1021 removes the college degree requirement for all levels of residential appraiser licensure. Of course, a four-year degree is valuable, but it is not the sole indicator of an appraiser's ability to assess a property accurately and fairly. This bill doesn't lower licensure standards, nor does it compromise the integrity of the appraiser profession. House Bill 1021 maintains all existing requirements, including extensive training hours, coursework from accredited institutions, examinations, and compliance with the Financial Institutions Reform, Recovery, and Enforcement Act of 1989. In fact, by regulation, the state of Maryland has already eliminated the college degree requirement for all levels of appraiser licensure, with the exception of the highest level, certified general appraiser. By removing this educational barrier, House Bill 1021 promotes workforce diversity by allowing a broader pool of candidates to enter the profession and expands opportunities for individuals who have been historically underrepresented in this industry. On House Bill 1021, I ask that you vote favorable. Thank you.
Thank you. My vice chair just said that's a good bill. That's a great bill. So thank you for your testimony. Do I have any questions? I don't see any questions. Thank you very much for your testimony.
Thank you.
Okay, that ends all our sponsor-only bills. We're going to go to House Bill 431. Delegate Stewart has Darren Thomas, his Chief of Staff, to present House Bill 431. And you have a panel, Fran Schneiderman and Stephen Sakamoto Wengel. You'll come up also.
I'll go ahead and get started. Good afternoon, Chair Beidel, Vice Chair Hayes, members of the Finance Committee. For the record, my name is Darren Thomas. I am Delegate Stewart's Chief of Staff, and I'm here to testify on his behalf on House Bill 431. He sends his regrets. I'll be brief because you've already passed Senator Waldstreicher's Senate Bill 413. But again, this bill prohibits companies from changing the statute of limitations period that the General Assembly created by burying language in the fine print of consumer contracts. Delegate Stewart is mostly okay with the amendments that this committee added to the Senate bill, including the amendments from the Maryland bankers. However, he respectfully requests that you pass a House bill that does not include the exemption for any business with a state business license. He's okay with the other exemptions that the committee passed, but he believes that exempting any company with a license conflicts with the intent and spirit of the bill. So thank you for your time. Happy to answer any questions, and we urge a favorable report with this one amendment.
Thank you. Steve?
Thank you. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Steve Sakamoto Wengel here on behalf of the Consumer Protection Division, the Attorney General's Office, here in support House Bill 431. As you may be aware, most consumer contracts are contracts of adhesion. That is, the consumer cannot negotiate the terms, but has to agree to the terms as presented. Unfortunately, in some of those contracts, the terms include limiting the time that the consumer has to bring an action if there's a problem under the contract, and that would be a period that is less than that provided under Maryland law. So we believe this bill is a matter of fairness to make sure that the statutes of limitation provided by the General Assembly are in fact enforced in consumer contracts. As Delegate Stewart's aide said, we do have concerns about the amendments that were placed on the bill, on the Senate bill, because those amendments would gut the bill and leave it so that virtually no companies would have to comply with the bill. We understand that regulated companies are in fact regulated, but most of those regulations have nothing to do with the statute of limitations for consumers who are harmed as a result of breach of contract or other issues. So we would urge a favorable report and hope that the bill is passed clean. Thank you.
Thank you. And Franz?
Thank you, Chair Beidel, Vice Chair Hayes, members of the committee for the opportunity to address this bill. My name's Franz Schneiderman. I'm with Consumer Auto Maryland. We're a nonprofit group that works for transparency and fairness for Maryland drivers and Maryland consumers. We support the bill, and I want to associate myself with the remarks that Darren and Mr. Sakamoto Wengel made. I mean, essentially, consumers need a fair chance to recover for damages. The state of Maryland established a 3-year statute of limitations, but the wisdom of the legislature, some companies are using their power over these contracts to essentially deprive consumers of access to that 3-year statute of limitation by using contract language that shortens it substantially. that hurts the ability of consumers to recover for damages and really interferes with the statutory scheme that the legislature, in its wisdom, provided. As Mr. Sakamoto Wengel said, I would encourage you to pass a bill that's much closer to the House version you're looking at here than to the version, the Senate version that was passed, the version that was passed in the Senate. The exclusion for all franchise operations, all licensed businesses, all regulated businesses is such a large exclusion that it really kind of swallows up the rule. It would mean that most consumer transactions wouldn't be covered by the protections that we're working to establish here. So it would really undermine the efficacy of the bill. So I hope you'd support the bill and pass a version closer to the House version than to the version earlier passed by the Senate. Thank you.
Thank you. Do I have any questions for this panel? Seeing no questions, thank you very much for your testimony. We have one unfavorable, Robert Enton.
Thank you, Madam Chairman. Robert Enton on behalf of the Maryland Bankers Association. As the sponsor's chief of staff said, they have no problem with the amendments that the Maryland bankers wanted. Those amendments would conform most of the bill to the Senate bill. The differences between the House bill and the Senate bill from the bankers' point of view have nothing to do with the provisions that you heard described. Our concern was that the House bill says that it's an unfair and deceptive trade practice to violate this. That was something that was not in the Senate bill. It's something we're very much concerned about, and the sponsor has no problem whatsoever with eliminating that information, that section which says that a violation of this section is an unfair and deceptive trade practice and is subject to the enforcement and penalty provisions contained in Title 13 of the Commercial Law Article. That language was not in the bill as introduced in the Senate. In addition, the Senate extended the effective date to June 1 of 26 so that small businesses in particular, but all businesses would know that their contracts can have a 1 year, going forward, can have a 1 year statute of limitations. So that's the reason why I signed a proposed, but once again, the House sponsor has no problem with conforming those provisions to the Senate bill by making the changes that I've described. Thank you.
Thank you, Mr. Enton. Do I have any questions for Mr. Enton? Seeing no questions, thank you for your testimony.
Thank you.
That ends the hearing on House Bill 431. I think now we're going to go to House Bill 850. Delegate Williams. Is someone here from Delegate Williams? Okay. Work group on the creation of data dashboard for public work contracts and apprenticeships.
Good afternoon, Madam Chair, Vice Chair, and members of the Senate Finance Committee. For the record, I am Michael Marino, Chief of Staff to Delegate Nicole Williams, and I will be testifying in favor of House Bill 850, also known as Work Group on the Creation of a Data Dashboard for Public Work Contracts and Apprentices Establishment. This bill is cross-filed with Senate Bill 3, thank you, Senator Ellis, and has been amended since its original introduction to provide for the establishment of a work group staffed by the Maryland Department of Labor to study the creation of a public-facing dashboard with information regarding workers and wages for ongoing public works contracts. This work group would solicit input from a wide range of stakeholders, including members of the House and Senate, a representative from the Department of Labor, a representative from the Office of the Commissioner on Labor and Industry, a representative of the Baltimore, D.C. Building Trades Council, a representative of the Mid-Atlantic Pipe Trades Association, and a representative of the Steamfitters Union Local 602. This work group would then provide recommendations to the Governor and the General Assembly on or before January 7th, 2027, on the best path forward for the creation of this data dashboard. We are also aware of a request that came in this morning from the Associated Builders and Contractors regarding adding further members to the work group, and will respectfully leave that consideration to this committee. Studying the development of such a dashboard with the end goal of its eventual implementation would reflect our state's commitment to transparency, fair wages, and the development of a skilled and competitive workforce. By working towards this, Maryland would demonstrate its responsible use of state resources to both workers and taxpayers while elevating our standards for equitable labor practices. For these reasons, Delegate Williams and myself urge this committee to give a favorable report on House Bill 850. Thank you.
Thank you. I'm looking for questions. I don't see any questions. Thank you for your testimony.
Thank you.
We have two favorable with amendment, Marcus Jackson and Kevin O'Keefe.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. For the record, my name is Marcus Jackson, Director of Government Affairs with the Associated Builders and Contractors of Maryland. I'm here in support of the bill with amendment, HB 50. ABC supports the intent of this bill. However, we believe that the current composition of the work group established by the bill could be significantly improved by including representation from non-union organizations. We believe that the work group recommendations will be more comprehensive and balanced if it include representation from organizations that operate outside of the traditional union framework. With that said, along with ABC, we believe also that the inclusion of both the independent electrical contractors, Chesapeake, and the Maryland Minority Contractors Association to be added to this work group would ensure that the data dashboard accuracy reflects the diverse landscape of public work contracts in Maryland. The amendment would ensure that the work group benefits from a wide range of expertise and perspectives, leading to a more robust and effective data dashboard. It's with this in mind that we ask for a favorable with amendment report on HB 850.
Thank you, Chair Bidle, members of the committee. My name is Kevin O'Keefe on behalf of the Independent Electrical Contractors Chesapeake. I agree with what Marcus said, and just want, if you look on my testimony, we have on after page 2, line 23, on page 2, line 23, you can insert the three IEC Chesapeake, Associated Builders Contractors, and the Maryland Minority Contractors Association, because I think each of those entities could add good perspective to this work group. And I know, for instance, Independent Electrical Contractors Chesapeake, we currently have about 1,000 apprentices. So we think that we could add to it, and it's important that both union and merit shops have the ability to say the best way to create this dashboard, which will be helpful to the public and to any organization that wants to see what's going on with public works contracts. So for that reason, we hope that this committee will support our amendments to add the three entities.
Thank you, Kevin. Do I have any questions? Seeing no questions, that ends the bill hearing
Thank
on House Bill 850. Next, we're going to do House Bill 1045. Delegate Jocelyn Penny-Melnick, Chair Jocelyn Penny-Melnick has Dr. Kay and Robin Elliott to present House Bill 1045. Dr. Catalina Rama, I should say. Thank you. Sexton here. Jamie, yeah, you can come to the table for questions. Thank you, Jamie.
Good afternoon. I'm Dr. Nilesh Kalyanarama, the Deputy Secretary of Public Health at the Maryland Department of Health. Thank you, Chair Bidle, Vice Chair Hayes, members of the Senate Finance Committee. I'm here on behalf of HGO Chair Penny-Melnick for HB 1045, which is a cross-file of Senate Bill 940, which was heard here and sponsored by Vice Chair Hayes. The Maryland Family Planning Program is our state's version of the Title X program. The Maryland Family Planning Program provides comprehensive reproductive health services for the state's most vulnerable residents. In fiscal year 24, the program served nearly 45,000 clients, with nearly 2/3 below the federal poverty line. In fiscal year 25, the program is predicted to serve more than 50,000 clients, continuing its post-COVID resurgence. And recently, the program celebrated a milestone with the addition of new family planning providers, ensuring that a Title X clinic is available in every single county in Maryland. These sites provide person-centered health care, both reproductive and non-reproductive focused, confidential services, medically accurate and unbiased reproductive health information, and affordable contraception. One of the reproductive services is referrals and counseling for abortions, which are critical components of reproductive health care. In 2017, in the face of an expected federal rule change to disallow Title X funded providers from offering counseling or referrals for abortion, Maryland became the first state in the nation to protect its Title X program through state statute backed with state funds. This body chose to safeguard the services provided by the Maryland Family Planning Program, and we wanted to ensure we were protecting health care access for tens of thousands of low-income reproductive age Marylanders. This bill is a technical update. The MFPP, the Family Planning Program, is already protected if federal funding were to be lost, as was believed would happen in 2017 and did happen in 2019. The current law took a snapshot, and we want to update that to the current date to December 31st, 2024, to allow for new programs that have entered the Maryland Family Planning Program. In just the past 2 years, program grew by 3 providers and 7 service sites who would not be included if this bill didn't pass. Of note, with regard to the insurance article in this bill, it contains insurance provisions that update the dates in our Affordable Care Act protection law to reflect December 31st, 2024, to provide the greatest protections for Maryland consumers. And the bill also clarifies the Insurance Administration's role in enforcing anti-discrimination provisions that are a mirror of the federal law. The department respectfully asks the committee to support this update so that the program can maintain continuity of family planning services should federal changes limit the current scope of services. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you, Dr. Kaye. Robin, are you going to also testify, or are you just here for questions?
I am mostly just here for questions. Robin Elliott on behalf of the American College of Nurse Midwives. I've been involved probably with all these different sections of law at some point and have the institutional history, so happy to answer any questions.
Thank you. And Jamie, you're just here for questions?
That's correct, Madam
Okay,
Chair.
so committee, do we have any questions for Dr. Kaye, Robin, or Jamie Sexton? Seeing no questions, we're going to go to the unfavorable. Laura Bogley.
Good afternoon again, Madam Chair, members of the committee. I am Laura Bogley, Executive Director of Maryland Right to Life. And we oppose this bill because it would increase public funding for the multi-billion-dollar abortion industry under the guise of family planning. It's a fatal mistake to entrust pregnancy prevention to an industry that profits from unplanned pregnancy, failed contraceptives, abortion, and the sale of aborted fetal remains. Since 2017, the state has shifted the burden to Maryland taxpayers to fund abortion businesses that disqualified themselves from federal family planning funds. This bill increases the annual maintenance of effort to be paid to abortion businesses in the state from $3.2 million per year to the 2024 amount under the Biden administration that the fiscal note does not disclose for you. Abortion's not a legitimate method of family planning, and that's why traditionally abortion businesses have been ineligible for federal family planning funding. Public investments in the abortion industry have failed to reduce unplanned pregnancies. In fact, the number of abortions has dramatically increased with public investments in Planned Parenthood. In its 2024 report, Planned Parenthood reported both a record revenues and a record numbers of abortion committed, nearly 400,000. Since 2000, Planned Parenthood abortions have increased by 245%. While Planned Parenthood is a significant provider of contraceptives, more than half of all unplanned pregnancies are a result of failed contraceptive. So we really need to examine what type of contraceptive care we're providing to women. Women in the state of Maryland deserve better options than abortion. We appeal to the state to prioritize funding for family planning programs that give women and men effective and safe alternatives to killing their children. We ask for your unfavorable report, and I'm happy to take questions.
Questions? Seeing none, thank you so much, and thank you for your testimony. Which bill? All right, that ends the bill hearing on House Bill 1045. Next, we're going to hear from House Bill 1104. Is there a representative from, oh, this is an administration bill. Elizabeth Crum, David Sharp. You may begin when you're ready.
Good afternoon, Vice Chair Hayes, members of the committee. I'm Elizabeth Crum, and I'm the Assistant Secretary for Population Health and Strategic Initiatives with the Maryland Department of Health. The department supports House Bill 1104 as amended before you. My testimony focuses on the Population Health Improvement Fund part of it. I do want to note to the committee that the department worked with the Maryland Hospital Association and its members on these amendments, and we sincerely appreciate their partnership and collaboration. One of the required elements of the state agreement with the Centers for Medicare and Medicaid Services for our HEAD model is that Maryland must create a dedicated fund for population health improvement. HB 1104 authorizes this fund to be established. The work supported by the fund has to align with the HEAD model's state health equity plan. This plan defines our population health measures and targets. It guides the state's activities aimed at meeting those targets. The plan's under development. It's actually due to CMS by July 1st. The Maryland Commission on Health Equity serves as the governing body for the plan's development. This group has new members as of October and now includes representatives from hospitals, health systems, and other clinical providers. The department intends to develop a set of guidelines to outline the eligibility criteria and the descriptions of the funding categories, as well as regular reporting requirements, and we're going to seek feedback from stakeholders on these guidelines. We'll also establish a review team to evaluate applications to the fund. And given that this is a pooled fund, it can accept money from public and private sources and other organizations. Any organization that contributes funding, we'd want to have a seat on the review team. The Population Health Improvement Fund provides a pathway to align public and private sources, resources to invest in the factors that drive health outcomes and impact healthcare utilization and costs. Thank you for your time and consideration of this bill. And David Sharp is here to speak about the other component of the bill, which relates to clearinghouse data.
Thank you, Dr. Crum. Good afternoon, Vice Chair Hayes and members of the committee. It is a pleasure to be here before you today. I'd like to talk to you a little bit about, as Elizabeth mentioned, the other component. As you may recall, the Maryland Healthcare Commission supports HB 1104, which clarifies that electronic healthcare transaction data may be used to support the state's participation in the Advancing All-Payer Health Equity Approaches and Development model. Current Maryland law allows the use of electronic healthcare transaction data for certain public health and clinical purposes. However, it does not explicitly mention an authorized use, which is for the AHEAD model. This creates uncertainty for electronic health networks regarding the permissible use of such data. Electronic health networks route administrative transactions, such as claims and eligibility data, electronically between providers and payers. By updating the statute to specifically include the AHEAD model, this bill will resolve electronic health networks' concerns and clarify that electronic healthcare transaction data may be used for the broader goal of advancing health equity and improving population health outcomes. HB 1104 is a crucial step toward enabling Maryland to meet the AHEAD model's performance requirements and goals of improving health equity and population health. The bill ensures that Maryland data sharing infrastructure continues to evolve in support of the state's ongoing healthcare transformation. Members of the committee, Vice Chair Hayes, for this reason, we stated above, we respectfully request a favorable report on the bill. Happy to answer any questions.
Excellent. Thank you so much. Senator Lamb.
Thank you, Vice Chair. So a question on this, I'm just looking through this and looking at the fiscal note. The fiscal note states that this new fund that's being set up would be partially funded by general fund dollars, I guess about $2.5 million out of federal dollars, and then $25 million assessed to the hospitals. So I guess kind of a fee that the hospitals are all paying into. Is that the general approach to this? This is just for the first fiscal year, right?
Right, this is just the initial piece. So it's back in December of '24, the HSCRC commissioners voted for a one-time $25 million increase in rates for calendar year '25 to support the fund contingent on passage of this legislation. So the hospitals will charge commercial payers, Medicare, Medicaid, a small amount more for the services than they otherwise would, and then that assessment goes back then into the fund.
And then what's the intention of how this will be funded in the out years? Because in the fiscal note, there's nothing there. So is this a one-time assessment to the hospitals, and then it would perpetuate itself based on just whatever funds are left, or is the intention that the hospitals would be assessed a fee in future fiscal years as well?
It's a good question. So that was the initial fund approved, initial dollars approved for calendar year '25. It says in the legislation that the HSCRC may assess in future years. It does not require them to do so, but they would have to go through their regular process of approval and voting in order to add anything onto rates in the future to go to this fund. This is also being set up as a public-private fund, so it can include other sources of funding, not just those that are based on assessments of rates.
So I guess to that other point about it being set up as a public-private fund, I guess, so to speak, where private dollars can also go into this. I think back to other models that we've had here in the state. I know, this was kind of referenced, and I think is in some of the documentation here. CRISP, for example, good private-public model that's been set forward by the state, doing amazing work, probably one of the forefront of those type of public-private models that the state has created over the years. And so wonder why this was not set up similar to CRISP, where it's actually being held a little bit more arm's length, where it's kind of an independent agency on its own. It has its own board, et cetera, whereas this public health trust fund is looking like it's housed within the health department. So it doesn't have its own board. It doesn't have necessarily the level of autonomy that you might see in some of these other kind of quasi-governmental entities that we've created.
Mm-hmm. Thank you for that question. So it's jointly administered by the HSCRC and the Maryland Department of Health, the fund would be. And we do have the Maryland Commission on Health Equity, who is serving as the governance structure for the AHEAD model and would be, as a part of its governance structure duties, having conversations related to this fund. That's also why we wish to set up an actual review team, set of guidelines and criteria for application, and anyone who's a part of paying into that fund would have a seat at the table in being a part of the review team to assess applications to use those dollars. I'll also just note that this is a requirement of our agreement with CMS, that this fund would be set up. So as the signatories of that agreement, both the HSCRC and the Maryland Department of Health, that's why it's jointly administered.
Yeah, and I get that, and certainly appreciate the Commission on Health Equity, which I know has kind of been remissioned or reconfigured for this. But, there are all of those kind of entities that you mentioned all fall within state government. That, for example, CRISP has its own board that's dedicated to the work that CRISP does. Commission on Health Equity, while this is an important part of that, this has been added on to its scope. Commission on Health Equity is also supposed to be looking at other things as well. It just seems like this gives a little bit less autonomy to this public health trust fund, that there are other models that we could have looked at. So, for example, MHCC, Independent Commission, has its own commission that oversees the work that's being done there. The Community Health Resources Commission, also its own set of commissioners, similar kind of charge, where it's taking in funding, although most of their funding is state budget dollars, but then designating out to awardees or grantees. I presume this is similar where the Public Health Trust Fund will be receiving dollars designated out to awardees, but doesn't have that level of independence that you might expect. And so it seems like it doesn't have its own board. The Committee on Health Equity, this isn't its sole responsibility. It's housed within the Department of Health. HSCRC obviously doing other things as part of their mission as well. So just trying to understand why this was set up this way as opposed to giving it a little bit more autonomy to do its work.
So I think the main piece of this is a part of the agreement, and it's pretty narrowly prescribed, the types of things that this can fund. So that's been outlined within our state agreement, and so we have to then set up a whole process of how we would go about accepting applications for that and review it. And with it being jointly administered by the HSCRC and MDH, and having also the Maryland Commission on Health Equity involved as the governance structure for the agreement that this is all based on, we felt that that was sufficient in terms of being able to identify criteria and eligibility and to be able to distribute from the fund.
So obviously, as you referenced, this is part of the AHEAD agreement. There were a lot of concerns, I guess, as the AHEAD agreement was moving forward with a really rapid pace. I continue to hear from stakeholders that feel like they didn't have as much input as they believe they should have had during the AHEAD kind of development process, and stakeholder outreach and as part of the agreement probably wasn't to the degree that many of us would have liked or hoped. And as a result, we continue to hear from that now. What's your sense of how this trust fund then would continue to have that proper engagement? Because, I think many of us we're concerned about and continue to be concerned about the outreach that I guess didn't happen as part of the AHEAD agreement, that we're still waiting to see happen now as we approach the July 1st deadline. And then we have this new trust fund being set up. What reassurance can you give us that there will be that level of stakeholder engagement that we haven't seen yet?
Mm-hmm. I appreciate the concern, and we've certainly heard that from stakeholders. I will say that what we've been going through since, I'd say, probably January with both the Maryland Commission on Health Equity, but also all the other stakeholders involved in thinking about both the state health equity plan that we're developing that includes a data advisory committee and thinking about the measures for all of that, is actually having meetings with various stakeholders to go through this and to receive feedback. So we've met with members of the hospital community, we've met with providers, we've met with MCOs, we've met with commercial payers, we've met with community trust brokers from community. We even have a work group of local health officers. So we've been really trying to solicit that feedback in a structured way and have included in that requests for feedback as it relates to the fund. With that as well, we've had conversations, thanks to communication with the governor's office around working with philanthropy. So talking with foundations in the state about how might they be able to be a part of this and what would that mean? And what does it mean if you pool funds? What does that mean in terms of decision making and who gets to decide what, who has a seat at the table? So I feel that we've been involved in a pretty deliberate process to incorporate that feedback and to seek out where there are questions and concerns.
So I'm assuming in the posture that this is coming over, then you would oppose an independent board being created for this?
I don't know if I can say right this second whether we would oppose or not, but I feel that the way that we've put this bill together and the way that we feel it should be structured for the fund, and have worked really hard with the Maryland Hospital Association too on amendments to make sure that it feels right for the Hospital Association and its members, and we feel confident in our ability to set eligibility criteria, a review team. We do have the ability to distribute good sums of money each year through the Maryland Department of Health through strong processes. So I think we're able to build upon that and run this fund and have it be in accordance with what we need to do for the AHEAD model.
Okay, maybe you can just clarify that for us later, because, I'm seeing testimony from the House side when this was an HGO that MedChi had suggested an independent board. Obviously, it was not added in the version that came over here. We're looking at this version now, does not have an independent board. Similar testimony being submitted by them. I'm guessing the posture of the department is to oppose an independent board, but, if you can get back to us on that, that would be helpful. Sure. Just to better understand kind of where the position of the department is. And then, obviously, this is all very tied to AHEAD, as you reference. And AHEAD, as we know, as the chair knows, as the Senate president is aware, we're all very concerned about the AHEAD model, given kind of the federal tenor of things right now and the risk that AHEAD may be under. I think some folks were trying to read tea leaves out of an announcement out of CMS a couple weeks ago. I'm not sure that that is predictive of what may or may not come down from CMS once Dr. Oz arrives there. So there's a lot of concerns there when it comes to AHEAD. What happens with this fund if AHEAD, for whatever reason or somehow, is pulled back by CMS?
Yep, it's a good question. And so that's actually one of the amendments that's in the bill that appears before you has been put in there, and that was thanks to our conversation with the Hospital Association. So this is tied to the AHEAD model. It also includes a sunset provision. So if the AHEAD model were to go away, this fund would not continue in perpetuity.
And what would happen with the funding, the $25 million that hospitals have already been taxed or assessed on that's going into the fund? Where would that funding go if the AHEAD model was dismantled? Do you have any sense from that?
So it can only be used for the purposes outlined in the agreement. So let me get back to you on that, because I know we'd have a process too. If there were any funds left over, we would have to then either return or put them somewhere because they couldn't stay. So let me figure out through talking with HSCRC what that would involve.
Okay.
And I can get back to you on that.
And then is there any perspective from the HSCRC side whether this would be something that would be assessed on a regular basis on hospitals moving forward, or is it more envisioned as like one-time assessments that they would be passing through the HSCRC to require that the hospitals pay this fee for, or is it predominantly going to be private dollar-driven? If you can give us a sense of that, that would be helpful too.
So the only thing that exists right now is this one-time approval, right, from back in December. So the bill allows that the HSCRC may go through its regular process to do an assessment, but it does not require it to do so every year.
Has there been any discussion at the HSCRC how they plan to replenish or repopulate the fund in the future years, or has that not been discussed yet?
So I cannot speak to that, but I'm happy to follow up.
Okay. I think that's it. All right, thank you,
Senator,
Madam Chair.
thank you for your questions. Do I have any other questions for this panel? Thank you very much for your testimony.
Thank you.
We have one unfavorable virtually, and that's Deborah Bricado.
Good afternoon, Senators. I'm Deborah Bricado with Maryland Right to Life. On behalf of our board of directors and members across the state, we ask for an amendment to exclude abortion purposes from this bill. Maryland Right to Life always opposes the expansion and taxpayer funding for abortion. The Abortion Care Access Act already requires taxpayer funding of abortion through Medicaid and requires private health insurance to completely cover abortion services. And on top of that, taxpayers are forced to pay for abortion training as a part of a special $3.5 million abortion training fund in the Maryland annual budget. The all-payer health equity approaches and development model, known as the AHEAD model, will expand the promotion and funding of abortion. Marylanders already pay tens of millions of dollars for the complete coverage of abortion. The Population Health Improvement Fund would be another special non-lapsing fund that claims to be for maternal and child health. In Maryland, abortion is considered part of maternal health care. Maryland Right to Life, of course, supports a fund that is used to improve maternal child health, but poll after poll shows that Americans and Marylanders prefer taxpayer money be spent for support of mothers and their unborn children over the funding of abortion. We oppose money taken away from that noble purpose and being used to commit abortions. We oppose the continued funding of the abortion industry and pharmaceutical companies for the deadly abortion pills. Do-it-yourself chemical abortions do not improve maternal health. This is yet another bill that allows the exploitation of the Maryland taxpayer for abortion. We ask for an amendment so that this bill and the Population Health Improvement Fund are limited to maternal child health as it relates to supporting the continuation of pregnancy. Without an amendment, we ask for an unfavorable report on House Bill 1104. Thank you.
Thank you, Deborah. Do you have any questions for this witness? No questions. Thank you for your testimony. That ends the hearing on House Bill 1104. We're now going to go to House Bill 1474. Megan Savella is here for Delegate Ann Kaiser. Megan.
Madam Chair Beidel and distinguished members of the Finance Committee, it is my pleasure to come before you and offer testimony in favor of House Bill 1474, extending provisions beyond the excellent Preserve Telehealth Access Act, which I believe you guys are all pretty familiar with at this point. This is a pretty small bill, and it passed unanimously in the House and had all of the Health and Government Operation Committee members co-sponsoring it. We have been meeting with the relevant licensing board members, and we incorporated many of their comments before the HGO vote. We do understand that now there are some new concerns, and we're willing to work with them to try and incorporate as many as possible. In its current form, as amended by the Health and Government Operations Committee, this bill creates a limited licensure exception for out-of-state licensed professional counselors to continue providing counseling telehealth services to their patients, students basically, that are temporarily residing in Maryland while enrolled in an institution of higher education. To use this exception, the student must have a pre-existing relationship of at least 6 months with the provider who is licensed in their home state. It doesn't apply to any student who establishes residency in Maryland or enrolls in a Maryland-based health insurance plan. Providers who intend to use this exception are also required to provide written notice, contact information, and licensing information to Maryland's licensing boards before providing any interstate telehealth services. We also worked out that a 3-year sunset makes sense for this bill, as it allows us to see if this process actually works. So you'll see in Delegate Kaiser's written testimony the entire background and why we believe that this is so important. But what it comes down to is that we want to increase access to mental health care for students in Maryland, and we believe that this legislation is necessary until the counseling compact is ultimately in place for all 50 states. We chose the limited licensure exception model specifically because they're already being used in various types of states, healthcare models, and also in various states to provide continuity of care for patients receiving treatment in states that are not their primary state of residency. You'll read more in the written testimony from Delegate Kaiser and the other favorable witnesses, but we basically wanted to use this as an opportunity to address some of the newer concerns that were brought by the board. So first, we understand that there's a concern about whether or not just being in good standing is enough of, good standing status is enough for a provider that wants to use this exception. And to that, we say, okay, we certainly can add in language that requires them to not have had any past or current disciplinary action, and we're happy to add that amendment if that's the case. Second, we understand that there will be an administrative burden increase, as is the case with most policy changes of this sort. We do want to clarify that we took that into consideration, and we made this bill in a way so that we're only asking the board to receive and hold on to the licensing information that's provided by the out-of-state providers using this exception and be able to provide it if there is an issue. Again, this is a pilot type of program, and we didn't want to choose something that created even additional administrative burden, such as temporary registration. It's also true that licensing standards are not the same in other states, but this bill is really about patient choice and continuity of care. These students have already selected with their families these providers in their home states, and while they're living in Maryland temporarily, we don't think that it's necessarily the case in which they should have to reevaluate those standards. In terms of the clinically appropriate treatment, neither Delegate Kaiser or I have the background to talk about, if that is or is not the case. What we can say is that we've heard from several providers that individuals have different needs, and providers determine what is clinically appropriate per individual. And as an educator, Delegate Kaiser would talk about the fact that finding a therapist for students is really not easy. They talk about it to their educators, and our campuses really do have a limited ability to serve students that need mental health care. On a personal note, I also graduated from the University of Maryland, and I worked at our on-campus crisis hotline for 3 years. Most of the calls that we got, the most severe ones, were from students who felt very, very isolated in Maryland at these institutions, coming from out of state places and losing a lot of their support system and these sorts of providers along the way. The last 2 points I'll address are concerns that this lacks inclusivity. It wasn't intentionally meant to target this specific licensing board or type of provider specifically, but we realized that other providers have pretty functional compacts that are already issuing interstate licenses. The counseling compact still has a little bit of a ways to go. They're only still piloting the program in 3 states that don't include Maryland this year. And we know that other states have chosen to start doing this either as a temporary or a permanent type of solution because of the limitations that come with those compacts, such as that not every single state will be included in them. Finally, this is a progressive health policy. Many of the states that are incorporating this, such as Illinois and Virginia, they're also leading the country in terms of other progressive health policies. They've been testing these policies out for a few years, and in our conversations with them, there haven't been significant issues to the point of which they would have to recall these policies or change them pretty drastically. So far, although this is our bill is specific to mental health care, therapy, and telehealth for Maryland students, there are 35 states, including Maryland, that already use the limited licensure exception model in different types of healthcare. And when states choose to enact this type of policy, they're doing it with the understanding that it really will benefit out-of-state individuals, sometimes more often than Maryland's residents. But the reality is that they're doing so because it's the right thing to do, and we're aiming at the end of the day to make Maryland a better place to live and to learn. And with that, I will leave the committee with just a reminder that this passed through the House unanimously with all of the committee co-sponsoring, and I will urge a favorable report on this bill. Thank you.
Thank you. Senator Lamb has a question.
Yes.
Yeah, thank you, Madam Chair. And you may need to check with the delegate on this, but so I was reading through the bill, appreciate that there's a real issue that we're trying to solve here by trying to improve continuity of care. But looking at how it's currently drafted, there isn't a way for the board to be able to discipline a licensed professional counselor who's practicing under the bill. And since the student is located here in the state of Maryland, it isn't clear that the board in their home state would have the authority to protect the student in this case. Wanted to see if the sponsor might be open to an amendment that would close a potential gap and ensure that there's at least a possibility of disciplinary action on bad providers.
Yes, absolutely. So when we were going through the House side of it, based on the initial feedback that we had received, we added in some of those provisions about how to notify the board and such, and some of these newer concerns are from literally yesterday, so we're ourselves looking to close the loop, but would absolutely accept committee amendments to do so.
Okay, and then last question here, and again, if you need to check with the sponsor, happy to get back to us. Would you be open to limiting this bill to states that aren't currently part of the compact? I guess the concern here that compact includes background checks and other important protections. So, the thought here being we should try to direct as many providers to the compact as possible.
I'll let Delegate Kaiser answer that specifically, but I know one of the things that we talked about when we first had the